Welcome. This interview is organized by the Maternal, Perinatal, and Pediatric Group Engaging Members, or GEM, of the American Society for Nutrition. We are one of the largest GEMs of ASN, and we are delighted to have a panel discussion today with three esteemed researchers and clinicians on the topic of complementary feeding. My name is Karen Lindsay. I'm an assistant professor in the Department of Pediatrics at University of California, Irvine, and I'm one of the committee members for our Maternal, Perinatal, and Pediatric GEM. And Stephanie, please, will introduce you.
My name is Stephanie Waldrop. I'm a pediatrician with specialty training and expertise in nutrition and obesity at the University of Colorado Anschutz. It is a pleasure to be here with all of you today and to listen to the perspectives of our panelists on a very important topic, complementary feeding in infancy. I want to sincerely thank our panelists for sharing their time and expertise with us today.
Hi, everyone, and my name is Maria Senzori, and I'm a doctoral student studying human nutrition at Michigan State University, and I am one of the graduate student representatives on the MPP GEM. Now, enough about all of us. I'm going to invite the speakers to introduce themselves. Dr. Elizabeth Wyden, let's start with you.
Hi, I'm Beth Wyden. I'm a registered dietitian and assistant professor at in the Department of Nutritional Sciences at the University of Texas at Austin. And I'm also I'm a member at large for the MPP RIS. My research at UT focuses on early life nutrition interventions, longitudinal methods, and body composition. And I currently lead a randomized controlled trial focused on diet and responsive feeding during infancy and its impact on self-regulation and obesity in toddlers.
Well, thank you. And Dr. Diab, please introduce yourself.
Hi, good morning. My name is Lillian Diab, and I'm an assistant professor at the University of Colorado, Anschutz Medical Center at the Children's Hospital. I'm a clinician. I do have some involvement in research, but I'm mostly a clinician. I have long experience in primary care, and then I pursued additional training in nutrition and in obesity medicine. So I'm a physician nutrition specialist. I'm currently the medical director of the nutrition clinic at Children's Hospital. I work a lot and counsel a lot of families about complementary feeding, normal feeding practices. I also work with a lot of kids with malnutrition and micronutrient deficiencies.
Awesome. Thank you for introducing yourself. And on to our last expert today, Dr. Tang.
Thank you. So my name is Minghua Tang. I'm an associate professor also from University of Colorado. And my research focus in the pediatric field is on how complementary feeding, how complementary foods affect infant growth, risk of overweight, body composition changes, as well as microbiome development. We conduct randomized control feeding trials in weaning infants and looking at different solid foods and how they affect the health outcomes that I mentioned.
Thank you so much. So it is wonderful to have all of our speakers here today as part of this panel interview. So I'm going to kick us off with our first question. And this is for each of our panelists. How did you get involved in this field, in your field of research? And could you elaborate a bit on your research in the area of maternal, pediatric, and perinatal nutrition specifically? Maybe we'll start with Elizabeth Wyden, please.
Okay. So I've been interested in pediatric nutrition, ever since I was a dietetic student in undergrad. But I didn't really, know about research or what that entailed. And it was actually during my dietetic internship that I got exposed to research at the NIH. And then I also began to really focus and hone in on early life pediatric nutrition just through my internship, where I basically asked my internship director if I could just specialize in that area. And she was like, sure, you can do 12 weeks of pediatrics if you want to. And so she let me do that, which was phenomenal. And that really gave me insight into the challenges that that infants face in the hospital, and then also out of the hospital in children who have really high risk nutritional needs. And that kind of laid the groundwork for me to then go on and get my PhD. My PhD work was focused on maternal and infant nutrition in the context of HIV, actually in Malawi, where we were working on a large randomized controlled trial where the mothers and the babies were randomized to receive mom antiretroviral drug, baby antiretroviral drug, or no drug. And then there was further randomization for the moms to receive a nutrient supplement to help prevent nutrient depletion during breastfeeding. And so my work on the project was really to focus on effects of the intervention on micronutrient status in the mothers, where we found actually adverse effects of some of these drugs on micronutrient status in the infants, and then also to look at mother-infant interactions. But that work really, led me to then go on and do work in the US context as a postdoc and then now faculty, because I recognized that a lot of the work that we were doing in Malawi also could potentially apply here in the United States. And so my work since that time has focused both on US and then US and then also global nutrition work. And it's really fun to do both areas. I've actually talked to a lot of colleagues about that, how it's like two completely different literatures. But then it also is, you can learn a lot from the different areas. So some of the work that I was exposed to as a doctoral student and postdoc that was going on in Africa, for example, with animal husbandry and giving people eggs to help promote infant nutrition, that really led me to do our infant feeding trial that's going on right now here at UT. So I think I answered that in a roundabout way, but we can go on to the next person.
That's great. Thank you. Such fascinating work. Dr. Diab, tell us a little bit about how you got into research in this field.
I was in primary care pediatrics for many years, and through work in my work, and work mostly in the non-for-profit setting where I was seeing very high-risk populations and witnessing the effect of rapid infant weight gain, and really got me more interested in pursuing additional resources for counseling and additional trainings. That led me to kind of do the training that Stephanie has done right now, but I kind of came to it also. I mean, Stephanie did some primary care as well. So I pursued the nutrition, the clinical nutrition fellowship. And from there on, I mean, you start and you see the additional need, and you feel like nutrition is also a modifiable factor that has a huge impact on developmental and health outcomes. So it becomes like beyond, and it becomes like more of a platform for advocacy. And I mean, this is an area also where our focus on helping minority and people with who are at disadvantage because of socioeconomic status or anything could have a larger impact. So I would say this is where I started. Again, my work is mostly in the clinical setting. I do have some research involvement looking at some iron status in children with malnutrition and looking at comparing nutritional supplement versus toddler's formula for infants who have malnutrition as well. But again, a lot of my work focus on the clinical setting and educating family and the treating malnutrition and micronutrient deficiencies.
It's amazing. Thank you so much for sharing. And Dr. Tang, please share with us as well your background.
Yeah, so I think I can be brief on this. So my overall interest started back in graduate school when I was working actually in adults, because my long-term interest is in obesity treatment and prevention. And when you do this in adults, it's mostly focused on obesity treatment. And working with Wayne Campbell at Purdue, if you know him, and you know that we do dietary protein and how that affects metabolic health and body composition during weight loss. So after graduated from Purdue, I came to CU to do my postdoc with Dr. Nancy Krebs, and switched gears from obesity treatment, which every now and then I wondered at that time and how effective this could be, to obesity prevention. And at that time, I think that was probably 12 years ago, there was this myth about the role of protein during infancy, mainly coming from infant formula having a much higher protein content than breast milk, and that could contribute to the rapid weight gain in formula-fed infants. Was the knowledge of the role of dietary protein in overall metabolic health, but mainly from the adult population. I conducted a pilot study in infants looking at different sources of protein from complementary foods and how that affect infant weight gain and risk of overweight. And that just triggered all the subsequent large-scale randomized control trials looking at different sources of protein, as well as now expanding to different types of solid foods beyond protein and how that affect infant growth and the overall health status. Yeah.
Awesome. Thank you so much for sharing. So our next question is actually also for Dr. Wyden and Dr. Tang specifically. Dr. Tang will let you go ahead and answer, but the question is, for those of us who may not be familiar, what exactly is complementary feeding? And would you consider formula to be a complementary food, or is the definition more strict?
Well, my understanding of complementary feeding is that it's the gradual introduction of foods beyond the liquid diet during infancy. And the liquid diet would include both breast milk and infant formula.
Yeah. Yeah, I concur with that. So I also agree that the food is designed to complement whatever milk type the baby is having. So if it's breast milk or formula, but things that aren't complementary foods are things like medicine. And so I feel like there's some confusion around that with families as well.
Thank you so much for sharing. I believe now Dr. Diab had some slides to share.
Okay.
Yes.
I'll
So now, yes, Dr. Diab, we'd like to kind of focus on definitions and understanding complementary feeding. And so given your experience within the clinical setting as a pediatric nutrition specialist, when should complementary feeding be initiated? And what food should be fed first?
So yeah, thank you. I prepared some slide, and actually I sort of like answered the first question as well, like was I mean, might be a good start point about the definition of complementary feeding. Definitely concur with like with Elizabeth and Manuel. But I do want to stress out the word dynamic, that the infant needs are dynamic and they're changing. And so is the food that should be. And this is like the feeding style and the nutritional need are it's constantly changing, and the complementary food need to complement that change, which formula does not do. And this is for me a huge thing why we cannot consider formula a complementary food. One of the things I want to stress out about starting and how we look at complementary food is it's like this period of time when complementary food is started is associated with a high activity in brain development. So this is again another modifiable factor, an area like a window of time where intervention can be essential in prevention and in optimizing developmental outcomes and health outcome. Like if we're looking at 6 to 2 years of age, this is part of that 1,000-day window, a huge part of it. And again, this is the time where complementary food is introduced. When I was looking at this panel, I love history, and I couldn't resist looking a little bit back and what happened, like how did all of this evolve? So to put it in perspective, the American Academy of Pediatrics was established in 1930, and before the AAP and having some formal recommendations, actually people were like staying a whole year, like saying not until a year. Like until kids can self-feed to start solid food. In the 1942, there was like a different perspective. They were starting cod liver oil at birth and some orange juice at birth. I'm not sure what's the orange juice for. It's like, was there some scurvy at that time? 3 to 4 months of age, we're starting with food rich with iron and egg yolk, and then like it goes from there. Changed again in 1959, where the emphasis became on potatoes as a canvas that you add things to it. So I really thought it's fascinating how things are evolving and where we are right now. I would say the most important consideration on when it comes to complementary food, like what to start with and how to time it, is really breast formula or mix, because this has a huge effect on our energy requirement, macronutrient and micronutrient needs. I put a brief example, like for me, when we're looking micronutrient, we're definitely thinking zinc, iron, and to a less degree of vitamin D. But specifically zinc, like starts really high in the cholesterol, but then it's really low by 6 months of age. Iron is low to begin with and stays low. But so again, all of these are factors when we kind of think of what to consider with starting complementary food. I did put a lot of emphasis on timing, and the current recommendation by the WHO and the AAP is 6 months of age, and especially for breastfed infant with exclusive breastfeeding lasting until 6 months of age. And a lot of studies cite the protection of infection, especially when it comes to the WHO for patients in underdeveloped country. However, this is a concept I want us to look at. So first of all, the GI tract is ready to digest and absorb all nutrients by 2 to 3 months of age. So there is no reason to withhold any type of food earlier based on the GI tract maturity. And I think timing consideration, looking at 6 months versus a little bit earlier than 6 months, we should think of growth, we should think of the risk of obesity, and definitely the prevention of allergic disease. So I looked at some studies, and especially looking at 4 versus 6 months of age. So there was a randomized trial where they took kids who are exclusively breastfed, and they randomized them to start food at 4 to 6 months of age. It's not a big sample, it's only 119 patients. And they found no difference in growth at 6 to 12 months of age between the two groups. First concept to throw in there is that, again, no growth difference if we start at 4 to 6 months, again, in breastfed infant. And that's, for me, is one of the most important things about timing as well, breast versus formula. Then the retrospective study that involved 847 patients, looking at the association between the timing versus risk of obesity, we find that among a breastfed infant, the timing of solid food introduction was not associated with odds of obesity. So whether you start at 4 or 6 months, does not have any effect on the BMI at 3 years of age. However, among formula-fed infants, introduction of solid food before 4 months of age was associated with a 6-fold increase in odds of obesity at the age of 3. So again, another factors to kind of keep in mind when we're thinking formula versus breast, and 4 versus 6 months of age. And finally, again, looking at a review of the literature, finds that introducing solid before 4 months of age may result in increased risk for childhood obesity, but that there are no difference at 4 to 6 months. So it seems to me from this review that 4 months, less than 4 months, is definitely, we could be looking at adverse effect in formula-fed babies, when in regard to obesity and overweight, but so 4 months is more of a cutoff than 6 months of age. Looking at the AAP recommendation for preventing atopic disease and the role of breastfeeding, so we find that exclusive breastfeeding for the first 3 to 4 months of life decrease eczema for the first 2 years. However, exclusive breastfeeding beyond 4 months of age was not associated with any prevention, with any additional protection of any type of atopic disease. Duration of but if breastfeeding, again, if we're not going to formula feeding, any breastfeeding that continue past 4 months of age is protective against wheezing in the first 2 years of life. And there are some studies that suggest that the duration of breastfeeding is also associated with protection of asthma until 5 years of age. There is no evidence on the duration of breastfeeding when it comes to food allergy. So looking at effect on growth, effect on risk of atopic disease, again, it seems like, 4 months is definitely a good exclusivity of breastfeeding for 4 months is definitely very important. But then looking at that 4 to 6 months area, it looks like we have a gray window. When it looks like when we look at type of allergenic food, there is no evidence that if we delay the introduction of allergenic food past 4 to 6 months of age, that will prevent atopic disease. And actually, the LEAP study, the learning about early introduction of peanuts, suggests that for kids who are at risk for allergy, those are kids with severe asthma or egg allergy, introducing peanuts at 4 to 6 months of age is protective from peanut allergy. However, we don't have data about other allergens to recommend early introduction. So I also looked about the introduction of wheat and the risk of celiac disease. This is a study that was published in the New England Journal of Medicine. And they took kids who had a first-degree relative with celiac disease and randomly assigned them to receive gluten at 6 to 12 months of age. The genotype was determined later at 15 months of age. And then they also did the serologic testing at 15, 24, and 36 months of age. And later on in life, they only did biopsy if the serology was positive. So when we find that neither the delayed introduction of gluten or the breastfeeding modified any risk of celiac disease, the most important predictor of celiac disease was actually the HLA genotype. So with this, and I'm happy to stop at any point if we want to focus on the timing right now. So with this, and I'm not making the case to start solid food early at 4 months. I'm just making the case to look at more at the infant readiness for solid food. In my practice, I see children who are breastfeeding and mom having some decreased supply at 4 to 5 months of age. And my go-to strategy in those kids is not to wait till 6 months to introduce complementary food. I prefer to fortify the diet and add the additional calorie using complementary food and cereal and meat as early as 5 months of age than to recommend supplementation with formula. And I feel like I have been very successful in having this mom go longer with breastfeeding until 9 months, 12 months of age by the introduction of complementary food that is high in protein and high in calories. Again, I'm happy to stop there. We can talk a little bit more about the timing. I don't know if this is the time we want to talk about what to feed, whatever. I see there are some questions might be in the chat.
Hi, Dr. Diab, this is really wonderful information, such a great foundation for our, understanding of complementary feeding. And I think we'll probably go back to a group discussion at this point. That's okay.
All right, to kick off the next part of the group session, which is more focusing on research rather than defining complementary feeding, in what areas surrounding complementary feeding do you see the most research needed, and where do you see research in this area heading? So this question is directed to everyone. Let's go ahead and start with Dr. Tang.
Hi. So I would say probably evaluating the health outcome beyond weight gain, or just trying to think what is the better way to phrase this. Because there are more important health outcomes beyond besides like how much weight the infant gains. As Dr. Diab mentioned, this is also a critical period for brain development. So when we evaluate what a certain type of solid foods would affect infant health, I would like to see if they were more inclusive of this type of health outcomes. For my own research, I am currently also focusing on the gut microbiome, which is not particularly considered a health outcome, but it seems to associate or have some direct impact on health outcomes of interest, including brain development, neurodevelopment, sleep activities, as well as weight gain in general. So yeah, that's my brief answer for that.
Thank you. Dr. Wyden?
Sure. So I totally agree with Minghua on that. I think, looking beyond just weight. So in my lab, we look at weight, obviously, like almost everybody else does, but then we're beginning to look at other outcomes that are really important to think about that are, a little bit harder to potentially disentangle effects of food or different food types or different feeding patterns on. So for example, we're doing measures of memory in infants at age 12 months and then 24 months. We're also really interested in responsive feeding and how that might impact the child's own ability to be in tune with their satiety and hunger cues, and whether babies that have more clear cues that they're showing during infancy, if that has an impact on how they eat as they get older and into toddlerhood. So right now we're actually measuring longitudinally in one of our studies the child's and the caregiver child responsive feeding, and then to layer on top of that, we're beginning to now code for the child's own cues, and then looking at how that longitudinally impacts the child's own ability to self-regulate during like a test meal. So we're doing an eating in the absence of hunger protocol in these babies once they turn 2, because that's when many of the other measures of self-regulation that are more common in like the human development type in psychology world, that's when you can actually measure them in 2-year-olds. But I just want to mention that, doing these types of assessments in young children is actually really hard. So a lot of the time the kids, like we do have, a pretty decent data, but sometimes the kids are just like, no, I do not want to do this memory task, and I'm not gonna do it. And so it's really actually very challenging to do these type of measures when you have diet prospectively measured, and then you're trying to look at developmental outcomes in the children. So you just need to have larger sample sizes and then also multidisciplinary teams to be able to do the work successfully. We actually had a certain task that we had pinpointed for measuring attention in our children that we're studying, and the task completely failed when we tried it on the 2-year-olds. So we then had to build a new task that works much better for 2-year-olds. So it's a lot of trial and error too with this particular age group, because 2-year-olds are incredibly hard to measure developmentally.
Awesome. Thank you. And Dr. Diab?
So I would love to see more research actually on baby-led weaning. So we see increased number of parents who are interested in this feeding method, and my literature, like my quick review of the literature, sometimes cite no differences in micronutrient, which like I myself cannot. I feel like is that really true? It seems to me that there are like parents who are pursuing this method of feeding are more college educated. So there might be some additional compensation that is protective in here, but I would love to see some research that examine that, compare baby-led weaning to other feeding methods. Or I think we do need more evidence on the current recommendation of introducing one food and waiting several days to introduce another food. I don't see it backed by any research that as a way to catch or prevent food allergies, but it has been the recommendation. And I think it's probably why some parents are just tired of it and they just want to feed their child, So we're seeing different ways of feeding are gaining popularity.
Can I comment? Sorry, I just want to echo what Dr. Diab said, because I've been doing controlled feeding studies in infants over the last decade, and the most recent large scale infant feeding study that we have started about 3 years ago, we're still enrolling. But before this one, I hardly ever had any moms ask me about baby-led weaning. But for this ongoing clinical trial, for now, I just checked, we have 37% of parents are either doing baby-led weaning or interested in doing baby-led weaning. But when we ask them, what do you know about baby-led weaning? They're like, I don't know. I just Googled it. And then the first results that popped up is what they are going to follow. It could be a random website that they would not even bother to check the credentials of the writer, or, it seems to give different messages overall. And parents also have this strong belief that they can only choose either purees or baby-led weaning. But most of the cases you can mix and match, or you can do both, or you can switch. So
we're coaching on complementary feeding with our families in our intervention program. And a lot of the families either want to do baby-led weaning, or they do the mixed version, or they're very traditional and only want to do traditional weaning. So we might be able to tease apart some of that, but I feel like people might have different opinions on what baby-led weaning is too. So there's like additional layers of complexity to that as well. I do feel like it's very important to advance our people's understanding of that, and then also potentially have, higher quality information available about it for consumers. I feel like, and I've talked to colleagues who were on the nutrition committee for the AAP, and they've stated to me that they don't want to tell people how to feed their babies. They'll only say what to feed babies. And I think that kind of limits the ability for us and then for others to actually counsel on it, because if there's not a real recommendation for it, that's clear, people will just be confused and then go searching for information in various places. I also feel like the world of social media in the world of infant feeding has really exploded, and there's a lot of really great resources there. And so I feel understanding where parents are getting their information from, and then how they evaluate whether or not it's good or not, also is a potential area of study too.
So now I'd like to get your perspective on what ways research has advanced our understanding of complementary feeding thus far. And we can start with Dr. Wyden, if you would like to go first, or Dr. Diab, or Dr. Tang, whoever has.
I can start. So I think, like, again, this field is evolving. I do think that, and I probably will be speaking about Dr. Tang research, because I do find myself actually implementing some of these concepts in practice, even though it hasn't made the way to the guidelines or to the AAP policies or anything. But looking at the type of protein and the association between the type of protein and future health risk, and which is all coming from research, has a big implementation again for practice. We know that most kids after the second year of life, yogurt, for example, is one of their main source of protein, and not as much meat. And then when we look, I think research is very informative in this area, that where we have to focus on our counseling and like counsel parents on what to feed their children and how much and what type of food should they focus on. So, and again, the field is evolving. I mean, the effect of the LEAP study has, in the last few years, has been huge. It has changed all of our recommendation around peanut and food introduction. So definitely the relation, research is giving a lot of information to clinician, And I feel like our job is to kind of bridge it and make it more accessible. And I'm
Yeah,
sorry if I spoke a little bit about your research, please.
yeah, I absolutely agree with Dr. Diab. I think a perfect example of translational research is the LEAP study. That there are a few products on market. Just trying to think of the name. I think there's one called Mother's Bliss and the other is called Spoonful One.
So funny enough that you mentioned Spoonful One, there was a class action lawsuit and now it's not on the US market anymore.
I see.
I'm gonna try and find it here. I'll look it up real fast.
Nonetheless, so that's just so both of these products, or for Mother's Bliss, it's a mixture of allergens in the powder form that parents can introduce to their infants, during the early complementary feeding phase. And this is, although the LEAP study is on peanuts only, but this type of products include other potential allergens as well. And the primary research base is the LEAP study. So I think that's one leap in this research. Yeah, that was my comment on that.
I totally agree. I think also, the work showing the different protein types impacting growth is also, one of the things that's really advanced our understanding. Also, we finally have dietary guidelines for this age group. There's still, I think, room for improvement in them where things could be potentially clearer for translation. So there's an emphasis on responsive feeding, but doesn't actually say to feed your kid responsibly. It just says responsive feeding is important, but it doesn't say you should do this. It just says it's important, but doesn't really give a charge for what to do. But hopefully we'll see in the next iteration of the guidelines potentially more clarity on that. And potentially, I'm hoping to see more clarity on the timing of introduction as well, and whether rapid introduction of foods will be recommended or not. The evidence is still not there. So I don't really know if it's actually something that can be easily studied. It's pretty tricky to actually measure that.
Yeah, that's a good thought. I mean, like introducing exactly at 6 months versus when infant shows more sign of readiness, because there are infants who are ready at 5 months.
So, all right, we're going to slowly pivot. What resources do we need to provide to primary care physicians and pediatricians to educate caregivers on not only appropriate, but personalized complementary feeding? It's kind of a tough one, so you guys can take a minute to think.
It would be great if we had resources on things like baby-led weaning and bringing the latest in the literature on protein for providers. I think it's also tricky though, because providers work with families from different backgrounds with different levels of resources, and so they also need to be tailored to people's circumstances and where they're coming from. So I think that there can be potentially like general documents available, and I think there are some on the dietary guidelines available, but they may not necessarily be able to be perfectly appropriate for families that providers are working with.
Yeah, I think from the previous topic that we discussed, there's still a lot to be done. And although the complementary feeding or infants and toddlers are included in the dietary guidelines, it's still very brief. So just to follow these guidance, there's not much PCPs can do at this point. I think. But one thing I could remember from my own experience and also from what moms from our infant participants told me is that the repeated exposure that has been recommended by PCP a lot. And that field, I think, is already have some well-established recommendation, like you need to try to introduce the same food over a certain period of time for how many times before you can consider my baby really doesn't want to take it. So yeah.
I think focus on food that is rich in iron and zinc is definitely an area that need emphasis with the primary care physician. We see a lot of parents who want to focus on fruit and vegetables, and fruit and vegetables are good for you, but for the breastfeeding infant, they don't check the box for like complementing the breast milk. So I was looking at also the use of cereal. I mean, I know in the US, we recommend fortified cereal versus the WHO recommending meat. 70% of kids, not 100%, which is like report taking cereal on a given day. So, and again, I mean, if that's your source of iron, that becomes important. So it's either cereal or meat. And also, it looks like there is this myth that meat should not be introduced until 8 months of age or 9 months of age. I hear this a lot of parents, so I think we need more education that meat can be introduced much earlier.
Do you hear the same thing about fish? I feel like with our families, many of them wait very, very long to give fish to their babies, and
Yes.
we don't entirely understand why.
Yeah, meat and fish. Yeah, but people like think like they can't give any meat until 9 months of age, and or like 8 or 9, and fish not until way later. So I think we definitely need a little bit more education about this.
I think some of the fear about giving meat and foods like that have more complex textures stem from a fear of choking. We see this in a lot of our families where there's just so much fear of choking, where people aren't advancing textures as they should be. And so I feel like maybe more support or guidance for providers to give families on that is also warranted.
Yeah, and I also feel like the popularity of the pouches, because there aren't that many pouches. I think there are some brands that have meat. They tend to be much more expensive. It's over $2 per pouch.
Mhm.
You know, the popularity of pouches have affected like the use of pureed meat, because parents are using pouches. And I also feel like some education is also needed about all of those excellent spill-proof containers, the ones that has the cereals that the kid can put his hand in, and the pouches and how they are encouraging a pattern of grazing.
Mhm. They really are.
That's a great point. And well, when we do controlled feeding studies, we provide commercially available baby foods, and we always, not always, but most of our feeding trials, we have a meat group. And there's really not much, or I want to say probably only 2 options, at least in Colorado, for weaning infants to choose as first food if they want to consume meat. And they're all like glass jars, because our study coordinator go to local supermarkets and they want to get those baby foods to provide to the participants. You can tell like they're either on the very top of the shelf or the very bottom, and they're all very dusty, so nobody seemed to want to get those. I know this is not like a chicken and egg thing, but the market demand is also low on meat products for infants.
So yeah, definitely we need more education about introducing meat.
Thank you so much. These have been really informative things to hear, that, you know, firsthand experience from interacting with families. And you've kind of already addressed a lot of the next question, but just in case there's anything else anybody would like to add about what are common barriers, concerns, or questions that caregivers have about complementary feeding, or are there any key myths still out there that you would like to dispel around complementary feeding other than things you've already mentioned?
I sometimes feel like, I mean, some of the barriers could be is like caregivers sometimes, like medical providers, sometimes we come to feeding with our own perceptions and ideas, and we have to be careful on what we also bring to the table. And also there are cultural things that the family come with, and sometimes the time of the visit, like with primary care, it's not a long visit and there are so many things to discuss. And I think it's very important to understand the family's cultural background and belief and how they think of and interact with food, and also deal with our own biases as well.
From our own experience, when we talk to parents, between different studies, I think we've enrolled more than 400 infants in the Metro Denver area on various different feeding studies. A lot of questions that we got is on parents' concerns of whether their baby is getting enough solid foods, or when they are reducing the amount of the liquid diet, whether it's formula or breast milk, how much solids am I supposed to feed my baby so she or he could have adequate growth? That seems to be the biggest concern, in my opinion. The good thing is we measure their baby every month, so that's reassuring. And also what food to start, we already covered that, and how to progress to different solid foods. I think we briefly covered that as well.
So our families in our study, we coach them on responsive feeding. So we take video of them and then we show them the videos of themselves. And then we use that to coach on the positive aspects of what we're doing. But some people pick it up right away, and then others need a lot more coaching to understand how to be sensitive. And so I'm more thinking about like what we can do to help providers coach families on that. And it's really tricky to figure out how to actually bring that into the session where you're trying to say, well, these are the foods that should be eaten, and this is potentially how you should feed baby, and these are the cues that baby's giving you, and bringing that all into something that's really brief and effective, I think, is tricky. And our parents want to be sensitive to their baby's cues, and they want to feed their babies in a way that will help them thrive. So helping them figure out how in a short period, I think, is the hardest part.
Thank you everyone for sharing. Unfortunately, it seems that we are out of time. I would like to thank you again so much to all of our panelists for joining today. We truly appreciated your time and your expertise on this topic, and we hope to see you at Nutrition 2024 this summer.
Thank you.
Thank you.
everybody.
Thanks.
So okay.